Hello everyone. In this video, we'll discuss about H. pylori therapeutics, treatment guidelines and pharmacology. So whether you are a pharmacy student, healthcare professional or someone looking to understand H. pylori treatment better, this video has you covered. So make sure to watch till the end and don't forget to like, subscribe and hit bell icon for more clinical pharmacy updates. Helicobacter pylori or H. pylori is a widespread bacterial infection affecting millions worldwide. It is a leading cause of peptic ulcer and if left untreated can significantly increase the risk of gastric cancer. But the good news is with the right treatment, H. pylori can be effectively eradicated. In this video, we'll explore the latest treatment guidelines and the recent updates in H. pylori therapeutics to help you stay informed and up to date. H. pylori is spiral-shaped gram-negative bacteria that colonizes the stomach lining. Once inside, it disrupts the protective mucosal barrier, leading to chronic inflammation and digestive issues. Symptoms can range from mild to severe and often include burning stomach pain, bloating, nausea, and indigestion. If left untreated, H. pylori can lead to serious complications such as peptic ulcers, gastritis, and increased risk of gastric cancer. More severe cases may result in bleeding ulcers, perforation of stomach wall, or obstruction which can require urgent medical attention. To confirm an H. pylori infection, healthcare professionals rely on several diagnostic testing, include UBT, it means urea breath test. It's a non-invasive test that detects bacterial activity. Second is stool antigen test. It identifies H. pylori proteins in a stool sample. Third is endoscopy, endoscopic biopsy or histology. It's a more invasive but highly accurate method, especially for complicated cases. Once diagnosed, proper treatment is crucial to prevent long-term complications. So in further video, we'll discuss about latest treatment guidelines and how to choose the best eradication regimen. According to the Canadian Association of Gastroenterology, the preferred first-line treatment for H. pylori eradication is quadruple therapy for 14 days. This approach offers higher success rate and is now favored over traditional triple therapy, which is only used in a select cases where antibiotic resistance is low. The guideline recommend two key quadruple therapy options based on patient factors and local antibiotic resistance pattern. Option 1 is PPI-based quadruple therapy. It's for 14 days treatment. This is a first-line option which includes proton pump inhibitor, twice daily dosing, which includes omeprazole, pantoprazole or esomeprazole. It reduces the stomach acid and enhances antibiotic effectiveness. Second is amoxicillin. Dose is 1 gram twice a day. A penicillin class antibiotic that disrupts the bacterial cell wall synthesis. Third is metronidazole. Dose is 500 mg twice a day. It's an antibiotic that damages the bacterial DNA. And fourth is clarithromycin. 500 mg twice a day. It's a macrolide antibiotic that inhibits bacterial protein synthesis. This regimen is highly effective in patients without clarithromycin resistance and achieve eradication rate over 85%. Now the second option is Bismuth-based quadruple therapy. It's also a 14 days treatment. This option is best for resistance cases. For the area with high clarithromycin resistance or in a patient with previous treatment failures, the preferred option is bismuth-based quadruple therapy. This includes proton pump inhibitor, twice a day dosing, bismuth subsalicylate, 524 mg QID means 4 times in a day, which acts as an antibacterial agent and a mucosal protective barrier. Third is metronidazole, 500 mg 3 times in a day to 4 times in a day doses that to disrupt the bacterial DNA. And tetracycline, 500 mg 4 times in a day, a broad-spectrum antibiotic that inhibits bacterial protein synthesis. This regimen is especially useful in a patient where clarithromycin-based therapy have failed or where resistance rates are high. By using a right regimen, we can significantly improve the eradication rate and prevent complications like recurrent ulcers and gastric cancers. While quadruple therapy is now the first-line treatment recommendation, triple therapy may still be used, but only if clarithromycin resistance is below 15%. There are 3 main triple therapy regimens, each lasting for 14 days. Option 1 is clarithromycin-based triple therapy. It's a preferred option. It includes proton pump inhibitor twice a day, clarithromycin 500 mg twice a day, and amoxicillin 1 gram twice a day. Option 2 is amoxicillin plus metronidazole based triple therapy. It includes proton pump inhibitor twice a day, metronidazole 500 mg twice a day, and amoxicillin 1 gram twice a day. Third option is clarithromycin plus metronidazole based triple therapy. It includes proton pump inhibitor twice a day, clarithromycin 500 mg twice a day, and metronidazole 500 mg twice a day. Among this, clarithromycin based regimen are more effective than those containing only amoxicillin and metronidazole. However, as clarithromycin resistance increases, the therapy are no longer preferred as first-line option. When you use this therapy regimen in right patient population, triple therapy can still achieve eradication rate above 85%. However, due to rising antibiotic resistance, it's generally not recommended as first-line therapy anymore. If first-line bismuth-based quadruple therapy fails, the next step is the second-line regimen that includes levofloxacin. Second-line therapy is for 14 days treatment, which includes proton pump inhibitor twice a day, amoxicillin 1 gram twice a day, and levofloxacin 500 mg once a day dosing. Levofloxacin is a fluoroquinolone antibiotic which inhibits bacterial DNA replication, making it an effective second-line option when first-line therapy fails. This regimen is particularly useful in cases where patients do not tolerate bismuth-based therapy or where the initial or first-line treatment fails to eradicate the infection. After completing treatment, confirming H. pylori eradication is essential, especially in high-risk patients. But who needs follow-up testing? Testing is recommended for patients with complications such as bleeding ulcers, perforation, or obstruction, as well as those with ongoing or recurrent dyspepsia after treatment. The best way to confirm eradication depends on patient's condition. The most commonly used test includes UBT, urea breath test, stool antigen test, and histology via endoscopy. If eradication is successful, the risk of reinfection is only about 1% per year. However, in patients with complicated ulcers, it's most important to continue proton pump inhibitor therapy until H. pylori eradication is confirmed. By following these guidelines, we can ensure a complete eradication, prevent ulcer recurrence, and reduce the risk of complication. Hope this video is informative and stay tuned for further updates. Thank you for watching. Stay healthy and stay safe.